This is part 2 of chapter 4, Diseases and Conditions of the Endocrine System. And the first thing I want to do is a quick review of the adrenal cortex hormones, because again you need some understanding of the normal to understand the abnormal. The adrenal glands secrete hormones that help regulate chemical balances, help regulate metabolism, like the mineralocorticoids that regulate the amounts of electrolytes that are retained in the body. Electrolytes are several different types of electrolytes, but the two that are most affected by the adrenal hormones would be sodium and potassium. Aldosterone, which is the main adrenal cortex hormone that's in this group called the mineralocorticoids, aldosterone, you need to learn aldosterone increases the reabsorption of sodium and the excretion of potassium. And I've used the chemical symbols here, Na for sodium and K for potassium, which you should know. Okay, so aldosterone increases the reabsorption of salt, increases the excretion of potassium. The glucocorticoids influence metabolism of sugars, fats, and proteins and have an anti-inflammatory effect. The most well-known of the glucocorticoids would be cortisol. Cortisol is an anti-inflammatory. There are synthetic cortisones produced, and we refer to those as the steroid anti-inflammatory drugs, like cortisone and prednisone. Solumedrol is one. From the adrenal cortex, hormones, androgens, estrogens, and progestins are referred to as the sex hormones. The main male androgen is testosterone, and females will produce a small amount of testosterone from the adrenal cortex. The males produce the testosterone from the adrenal cortex and from the testicles. The adrenal cortex also produces estrogen and progestin. And the ovaries in the female produce estrogen and progestin. Now, a male will produce small amounts of estrogen and progestin from the adrenal cortex. Okay, so those are the three main groups of the adrenal cortex hormones and an idea of what they do. Aldosterone, the main mineralocorticoid, the glucocorticoids like cortisol, and the androgens, estrogens, and progestins. Okay, adrenal gland diseases. This is Cushing syndrome, which is hypersecretion. Again, too much secretions, hyper. Now, if you will recall, the pituitary gland produces the adrenocorticotropic hormone, which stimulates the adrenal cortex. There are many different reasons to have this hypersecretion, this Cushing syndrome. One of those reasons would be the person has a tumor of the pituitary, and the pituitary is hypersecreting ACTH that causes hypersecretion of the adrenal gland. It could be that the person has hypersecretion because of a tumor of the adrenal gland, that the adrenal gland itself has a tumor and is over-secreting. Cushing syndrome can also develop because of the use and overuse of corticosteroids, such as cortisone I mentioned a few minutes ago. Okay, in Cushing syndrome, there's very distinctive body pattern where the person develops what's referred to as a buffalo hump. It's a fat deposit form in the scapular area of the back, like between the around the scapula, the shoulder blades in the back. They'll also develop those fat deposits in the trunk, and it looks like their abdomen is protruding. Because of the salt retention, which again, think about the aldosterone. The aldosterone produced from the adrenal cortex causes sodium to be reabsorbed in the body. So if we have too much secretion of aldosterone, too much sodium is retained and too much water will be retained, causing the edema, and especially edema of the face, that the person will develop what's called the characteristic moon face appearance. There's a really good picture comparison in your book. Picture A is the person that has Cushing syndrome before treatment, and picture B shows the person after treatment, and their face is no longer round and moon-shaped. So I talked about the hypersecretion of aldosterone causing too much sodium to be reabsorbed, which is hypernatremia, and at the same time the hypersecretion of aldosterone causes potassium to leave the body. So the person ends up with hypokalemia, a deficiency of potassium in the bloodstream. Cushing syndrome. But let me back up before I talk about Addison's. As far as the treatment of Cushing's, it depends on the underlying cause. Is the cause a tumor of the pituitary, causing excess ACTH? Is the cause a tumor of the adrenal gland that needs to be treated by surgical removal or radiation? Is it an overuse of corticosteroids? Drugs can be used that will decrease the level of ACTH suppression. So the treatment depends on whatever the cause is. Okay, now opposite from Cushing's is Addison's. Addison's is hyposecretion, or an insufficient secretion from the adrenal glands. And you notice in hyponatremia, the person is going to have hyponatremia. Natra is the sodium. The aldosterone produced by the adrenal gland causes you to reabsorb sodium in the body. So if you don't have enough aldosterone, you will lose sodium and end up with hyponatremia, and at the same time, hyperkalemia. The kalemia part is the potassium in the bloodstream. Aldosterone causes potassium to be excreted. So if you don't have enough aldosterone, the calcium will build up in the bloodstream. When you look at the signs and symptoms of the Addison's disease, many of them have to do with electrolyte imbalances, and I failed to mention when I was talking about Cushing's also that Addison's or Cushing's, either one, will cause emotional problems, will cause anxiety, depression. The Addison's will result in weight loss. We're just opposite of that is Cushing's, where they have weight gain. And the treatment of Addison's is the hormone therapy for life, is to find out what the underlying cause is and to supplement with hormones. Replacement of the natural hormones, correction of the hyponatremia, correction of the hyperkalemia. And to try to avoid what's called the Addisonian crisis. When you look under treatment in your textbook, they describe the Addisonian emergency, which is life-threatening. Okay, now your book doesn't include this, but I'm including this because I think it's very important to realize the adrenal medulla hormones, epinephrine and norepinephrine, and how important these are to the body's normal functioning. Epinephrine is called adrenaline, and you've probably heard of adrenaline. It increases your cardiac rate, dilates bronchial tubes, stimulates the production of glucose, all in response to either emotional or physical stress. And noradrenaline, or norepinephrine, also allows the body to react to stress by constricting blood vessels, raising blood pressure, Now the hope is that when the stressful incident has passed, that all of this will go back to normal again. If the person has an adrenal medulla tumor, that tumor will cause them to be in a state of hypersecretion of the epinephrine and norepinephrine. Therefore, they'll have really high blood pressure. They'll have severe headaches, sweating, muscle spasms, palpitations. They'll feel the heart racing. The tumor of the adrenal medulla is referred to as a pheochromocytoma. Treatment would be surgical removal of the tumor. And of course, after surgical removal, then the person's going to have some problem with the hormone production. But the pheochromocytoma will be life-threatening because of the extreme high blood pressure and the possibility of the stroke because of the extreme high blood pressure. Okay, the next gland to talk about is the pancreas. The pancreas is considered both a exocrine gland because of the pancreatic juices secreted to help with digestion, and the pancreas is considered an endocrine gland because of the secretion of insulin and glucagon. Insulin is probably the best known of these secretions from the pancreas. This is what insulin does. Stimulates the conversion of glucose to glycogen and allows sugars to pass from the bloodstream into tissue cells. Okay, what you have is that when the body takes in sugar, and I'm going to simplify this the best I can to help you to understand on a very basic level, that when you eat food that has sugars, and I don't mean just processed sugar, I mean plants, the good kind of sugars too that you get from vegetables and fruits. You take in the food in your digestive system, the sugars are absorbed into your bloodstream, and you'll have a high glucose level right after a meal, and part of that glucose will be stored in the liver in the form of glycogen. Well, it's insulin that causes the glucose to convert to glycogen to be stored in the liver. You're also going to have a certain amount of sugar in the bloodstream at all times. You've got to have just the right amount of glucose. Not too much, and certainly enough. The balance has to be maintained. So you eat this big meal with sugars, you eat plants. I laugh about us eating plants. We eat fruits and vegetables, but they have sugars. The glucose is in the bloodstream. You need some of it to be stored as the glycogen, and then you need the sugar to be processed in such a way that it is allowed to pass from the bloodstream out to the tissue cells. The tissue cells, the rest of the body cells that are outside the bloodstream. I kind of compare the sugar, the glucose that's in your bloodstream, and the need that your tissue cells have to comparing the need that your car has for gasoline. It's gas that causes the car to function, causes the car to run. It is glucose that allows the tissue cells to function. You've got to have the glucose at the tissue cells so that they can function. And you've got to have the insulin to allow the sugar to pass from the bloodstream into those tissue cells. So if the person doesn't have enough insulin, their blood sugar level is going to be really, really high. They need the insulin to allow the blood sugar to pass into the tissue cells for the cells to work properly. So when the insulin is actually produced from the pancreas, it causes a reduction in blood sugar level. When the insulin is produced, it causes some of the glucose to convert to glycogen and some of the glucose to go out to the body cells. insulin decreases blood sugar levels. Now, on the other hand, glucagon produced from the pancreas causes that glycogen, that stored sugar in the liver, to break down and be released again as glucose. Glucagon raises the blood sugar level. And then when the sugar level goes up again, insulin is produced to help the sugar get out to the body cells, which then again lowers the blood sugar level again. And it's just a constant balance. If everything's working properly, it's a constant balance in your body between the insulin and the glucagon to keep the blood glucose level just right, and at the same time keep the tissue cells with their fuel coming to them. Okay, you've probably all heard of diabetes mellitus. The diabetes mellitus is a problem with insulin production. If a person does not have enough insulin, then their blood sugar level is going to increase. Remember, we count on the insulin to decrease blood sugar level and take the sugar out to the body cells. We count on the insulin to allow some of that sugar to be stored as glycogen in the liver. If you don't have the insulin, then you develop hyperglycemia, too much sugar in the bloodstream. And when you start having this hyperglycemia, too much sugar in the bloodstream, the cells are not getting the sugar that the blood cells need, then the sugars they increase in the bloodstream, and they start doing what we call spilling over into the urine, where the person will start having sugar in the urine. But while the person has this increased sugar in the bloodstream, their body cells are starving for the sugar. They're not getting the fuel they need. And what happens to your car when it stops getting the gas? It stops running. So when your body cells can't get the sugar they need, they'll actually first start metabolizing, breaking down fats and proteins. When that happens, you end up with a high acid level in the bloodstream, and these what we call ketone bodies start showing up in the bloodstream and spilling over in the urine, and the person may go into a state of what we refer to as ketoacidosis, which is a life-threatening situation. Okay, when I talk about not enough insulin or decreased insulin levels, I'm talking about diabetes mellitus. It's described as a disorder of carbohydrate, fat, and protein metabolism due to inadequate production of insulin or due to the inability of the body to use the insulin properly. Diabetes mellitus. There's decreased insulin. Some cases there's no insulin produced. Some cases the person will produce the insulin, but their body just doesn't use the insulin properly. The principal symptoms that a person will tell the doctor about will be increased thirst and increased urination, polyuria, and polydipsia. When you look under signs and symptoms of diabetes mellitus, the hyperglycemia is the root of the problem, this increased blood sugar level. The person complains of going to the bathroom too much, polyuria. Also polyphagia, they want to eat too much. Polydipsia, they're really thirsty. In the most extreme cases, they'll have weight loss. But I'm going to talk about the difference in the weight loss and weight gain in people with diabetes in just a minute. They'll have fatigue. The two primary types of diabetes mellitus. Type 1 used to be called, and I'm saying used to be, it formerly was called insulin-dependent diabetes mellitus. These people that have type 1 diabetes mellitus truly are insulin-dependent. They cannot live without insulin injections. The patient that has the true type 1 usually develops the type 1 diabetes as a child. One time formerly, it was called juvenile diabetes. In most cases, it occurs before the age of 30, and they produce very little insulin or no insulin. And I've put it bold here, they are dependent on insulin injections for life. They will be on long-term insulin therapy. And they have to control their diet and receive the proper amount of exercise. They have to monitor their blood sugar levels often. The patient education is essential in the treatment of type 1 diabetes mellitus. Okay, the type 2. Type 2 was formerly called non-insulin dependent diabetes mellitus, and it kind of is non-insulin dependent. If the person can control their diet and exercise properly, then they won't need the insulin injections. There are also oral medications that sometimes the person with type 2, they control their diet, they exercise properly, they take the by mouth, the oral medications, and they will not need the insulin. But it's really hard for anybody to control diet and exercise properly, and some people it's very difficult to take in medications like they're supposed to. So if a patient cannot control diet, exercise, and take those oral medications properly, they become dependent on insulin injections. That's the type 2. If they would control diet and exercise and take the oral medications, they would not have to take the insulin. And that's different from, and I'm going to back up, that's different from type 1. Type 1 diabetics do not have the choice to take oral medications. They must take insulin injections. And along with the insulin injections, they must control diet and exercise. There's no choice here. This type 1 usually occurs early in life, but they have it forever. The type 2, these people that develop type 2 are usually overweight, usually after the age of 30, but an alarming statistic that we're seeing in the United States now is that there are more and more children developing type 2 diabetes because of their diet, their overweight, and lack of exercise. I've listed here some of the oral medications that are used for the type 2 diabetic. And again, patient education is essential in the treatment, educating the patient about exercise, diet, and medication. There are many, many different complications in many systems, and almost every system in the body in the patient that either has untreated or poorly managed diabetes. Even with good compliance, diabetics are really prone to a number of complications. It's so important to diagnose the diabetes early, including using a urine test to detect the amount of glucose in the urine, which there should not be any. There's blood testing for glucose levels. There's glucose tolerance test, also called GTT. There's fasting blood sugars, FBS. Diabetics' sugar level can range from 300 to 1200 or even higher. Truly, the normal blood glucose level, it will fluctuate a little bit, but it should be somewhere between 90 and 120. If the glucose level is running well above 120 and the 190s and the 200s and even above that, the person should be evaluated for diabetes mellitus through the fasting blood sugar test and the GTT. After the diagnosis is made of diabetes mellitus, whether it's type 1 or type 2, the person has got to be trained in monitoring glucose levels at regular intervals because the person has to respond to their blood sugar levels. If their level is too high or if their level is too low, they have to know what the correct response is. Those complications that I talk about, the secondary complications, these are long-term complications, and even with good control, the person's very likely to develop diabetic retinopathy and even blindness because of the diabetes. diabetic nephropathy, which is kidney disease because of the diabetes. Diabetic neuropathy, which is disease condition of the nerves because of the diabetes. In diabetic neuropathy, the person may actually have such neurological problems that they do not feel their feet, that they could step on a tack and not feel that kind of pain that I sure would feel. The person that has diabetes mellitus has an increased susceptibility to infection. They don't heal as quickly as people without diabetes. They're more prone to atherosclerosis. Atherosclerosis is when the fatty material builds up in the arteries, which leads to strokes or cerebrovascular accidents. Atherosclerosis leads to heart attacks. The medical word there, myocardial infarctions. What we consider primary complications include the ketoacidosis. And I mentioned that a few minutes ago. When the body cells are not receiving the sugar supply, they begin to improperly break down the fats and proteins, releasing these ketones in the bloodstream that are very acidic. They develop ketoacidosis. They may go into a coma. They may die from ketoacidosis. It should be a fear of every diabetic. That should be a stimulus to carefully control and monitor their blood sugar levels and their insulin and diet and exercise. The patient who has type 1 is much more prone to developing ketoacidosis. The person that has a coma due to ketoacidosis has that coma because of a lack of insulin, and their blood sugar levels grow too high and their body cells aren't receiving the sugar. A person that has diabetes may also develop a coma when their blood sugar levels get too low. If they take an injection of insulin that again is going to lower the blood sugar level, take the sugar out to the body cells, and they don't eat enough food in response to the amount of insulin they've taken, then they may become hypoglycemic and go into a hypoglycemic coma. I want you to look in your book at the table 4.3 that shows the warning signs and interventions for diabetic coma versus the insulin reaction coma. The diabetic coma is when the person does not have enough insulin and their blood sugar levels are way too high. And they're the ones that have the acidosis, the dehydration, and they need immediate treatment. The breath will have a fruity smell to it. Their skin's flushed and dry. They'll grow drowsy and eventually go into a coma. The treatment is insulin. They need insulin and they need control of dehydration. On the other hand, there's the insulin shock, where the person has taken too much insulin or has not eaten enough food, or maybe they have exercised excessively. That's the hypoglycemic shock. These are the people that actually need sugar in some form. They need sugar because they are in insulin shock. Again, lightheadedness, faint, trembles, going into coma. They become more and more drowsy. So either hyperglycemia or hypoglycemia can cause the person to go into shock. And anyone in the medical field, the physical therapy assistants, the nurses, medical assistants, anyone who is caring for a patient needs to recognize the difference in diabetic coma and the insulin shock, because the treatment is just opposite. And both of these can be life-threatening. As far as gestational diabetes occurs when a person's pregnant. If it's truly gestational diabetes, it occurs only when a person is pregnant. The person that has true diabetes mellitus that I just talked about, the type 1 or type 2, when they become pregnant, they'll have numerous complications. It's just part of being a diabetic and being pregnant. Now, the gestational diabetes occurs in someone who has never had diabetes before, and they develop the problems with insulin and the ineffective insulin action because they're pregnant, during the pregnancy only, and they have polyuria, polydipsia, polyphagia. Actually, those are pretty much symptoms of pregnancy, but having that routine urine screening during pregnancy is just essential to detect if what they call sugar is spilling over in the urine or ketones start showing up in the urine. Treatment's going to be the same for non-gestational, but it's just so important to be aware that the person's developed these problems, and they'll have to control diet, exercise. They may even have to take insulin injections while pregnant. The gestational diabetes should certainly disappear after pregnancy, after delivery. And it may take a few weeks, but it should completely disappear after pregnancy. Other disorders of the pancreas would include hypoglycemia. Now, hypoglycemia, again, it's a low glucose level in the blood. And the problem could be with the pancreas, but there's other causes of hypoglycemia also. We consider that the person is hypoglycemic when they have a blood glucose level below 50. Symptoms: faintness, sweating, nervousness, palpitations, mental confusion, maybe irritability. The severe hypoglycemia may cause the person go into a coma, may even cause death. Treatment depends on the cause, and it's just so important to completely evaluate the patient to know if the hypoglycemia has been induced by an insulin injection or some other medication, or if it's just because they failed to eat a meal, or maybe they exercised too much without eating properly. And this is really not common in people that exercise too much. I don't want to discourage anyone from exercising. You just want to make sure that you are healthy enough to exercise and you don't start having symptoms from overexertion. A person with a significantly elevated blood alcohol level may also go into alcoholic hypoglycemia. So treatment depends on the cause, but definitely the glucose level must be corrected, must be returned to normal. Okay, moving from disorders of the pancreas to disorders of the ovaries and testicles. I want to talk just a little bit about this because I truly talk about the disorders of ovaries and testicles when I teach the reproductive system. Overproduction of hormones from testicles and ovaries may cause a number of different problems, but the conditions I'm going to talk about with this chapter involve the overproduction of hormones from the gonads early in life in a child. Precocious puberty in boys is manifested by early development of secondary sex characteristics, early gonad development, early spermatogenesis. The normal puberty occurs between the ages of 13 and 15. Precocious puberty, the onset of puberty is before the age of 10. Treatment depends on the cause. There are hormones that can be used to suppress the sexual maturity. The person's going to need some mental health counseling. The family's going to need mental health counseling because of the unusual activity of these very young boys. And on the other hand, this precocious puberty could occur in the females also, which again would be the development of secondary sex characteristics like breast enlargement before the age of 8, menstruation before the age of 10. The person has the increased sexual maturity at a very early age with precocious puberty. Treatment depends on the cause. Hormone therapy may be again used to suppress the gonads, and mental health counseling is a very important part of this. This concludes the lecture on Chapter 4, Diseases and Conditions of the Endocrine System.